Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Mass Maker sessions. We will be running through a question with you guys to help you on your journey to a 250. So what is the most likely diagnosis for this patient and what is the appropriate initial management? A 40-year-old man presents to the emergency department with complaints of sudden onset epigastric pain described as a burning sensation along with nausea and several episodes of non-bloody vomiting. He reports a recent history of consuming a large spicy meal at a local Mexican restaurant. Physical examination reveals tenderness in the epigastric area, but there are no signs of peritoneal irritation. The patient's vital signs are stable, with a blood pressure of 120 upon 80 and a heart rate of 80 beats per minute. Lab tests show no abnormalities in complete blood count and basic metabolic panel. What is the most likely diagnosis for this patient and what is the appropriate initial management? Acute appendicitis, acute gastritis, peptic ulcer perforation, acute pancreatitis, gastroesophageal reflux disease, and antacid therapy. So here we can see that the patient is having a complaint of sudden onset gastric pain, and which is burning sensation and a non-body vomiting. Okay, if there have been peptic ulcer perforation, then there have been first of all bloody vomiting if the patient is vomiting at all. Then the patient has a history of consuming a large spicy meal at a local Mexican restaurant, which means that the patient had consumed an unhealthy diet. So you know the mnemonics: hurry, worry, and curry that predisposed to the peptic ulcer or the that uh, predisposed to the gastritis. So maybe this person is having acute gastritis. Let's rule out other option. The patient do not have signs of peritoneal irritation. It means that the patient is not having acute appendicitis or acute pancreatitis. Talking about the gastroesophageal reflux disease, it is not sudden. The patient has the burning sensation or the retroexternal chest pain, but it is generally in the uh, night time or when the patient lies down. Now also we can see that the lab tests are completely normal with complete blood count, which means that the patient is not having appendicitis or pancreatitis. Then what is the most likely diagnosis in this patient? So the most likely diagnosis is acute gastritis, and the management is initiation of PPI therapy. But we also discussed about the explanation. So the most likely diagnosis is acute gastritis. The key findings include the sudden onset epigastric pain, nausea and vomiting, recent spicy meal, physical examination findings such as tenderness in the epigastric area, and stable vital signs. Which means that the patient is not having a severe or life-threatening condition like acute pancreatitis or acute appendicitis. So the sudden onset epigastric pain, the patient presents with sudden onset epigastric pain that is described as a burning sensation, and this type of pain is characteristic of acute gastritis. The presence of nausea and non-bloody vomiting is common in acute gastritis and is often triggered by the ingestion of irritating or spicy foods. The recent spicy meal intake is a potential trigger for acute gastritis, as spicy or irritating foods can exacerbate the condition. Physical examination findings reveals tenderness in the epigastric area, a common finding in acute gastritis. Importantly, there are no signs of peritoneal irritation, making conditions like appendicitis or peptic ulcer perforations less likely. But in my video, we don't only discuss the questions, we also discuss some of the important topics that are usually tested in the USMLE step 1 examination. So in this video, we will be discussing about the stomach anatomy, the gastric acid secretion, and the peptic ulcer and gastritis. So here in this slide, you can see we have kept a picture of the stomach anatomy. So this is the gastroesophageal junction, and from there, this is the cardia of the stomach. The fundus or the head of the stomach is usually here. And in the case of congenital diaphragmatic hernia or the esophageal hernia or something like that, this fundus just protrudes upwards. And then you can see this is the lesser curvature. The smaller curve is called as the lesser curvature. The greater curve is called as the greater curvature. The main body is here, and then there is the pyloric antrum, pylorus, and then there is the duodenogastric junction. Now, this is just a microscopic animation of the gastric cells and all. So here we can see that we have the chief cells, the parietal cells, the mucus secreting cells, and then also we have the surface mucous cells and the gastric pit, That is this here. Now we have discussed about the histology of the gastric stomach and all in previous videos. So I request you to refer to that. Now talking about the blood supply of the stomach, the important arteries that you need to know is the left gastric artery, the um, right gastric artery, okay, right gastric artery, the gastroduodenal artery, and the left gastroduodenal artery. Also, the splenic artery, which is a branch of the celiac trunk. This is also tested in correlation with some hepatic pathologies and all. And short gastric artery supplies the head of the or the fundus of the stomach. So in this picture, what you need to know is about that the short gastric artery supplies the fundus of the stomach. Then this part is supplied by the left gastric artery, and this is supplied by the right gastric artery part, and also there is supply from the gastroduodenal artery and all. And let's talk about the different types of cells and their secretion. So previously in the picture, you have seen the parietal cells, the chief cells, the G cells, and the mucous cells. Now the parietal cells are located in the body of the stomach, and they secrete the HCl and the intrinsic factor. The chief cells are also located in the body of the stomach, and they secrete the pepsinogen. The G cells are located in the antrum of the stomach, and they secrete gastrin to circulation, and this gastrin increases the gastric acid or the HCl secretion. The mucous cells are also situated in the antrum of the stomach, and they secrete mucosa pepsinogen. Now talking about the acid secretion, so whenever there is intake of the food, we ingest the amino acids or peptides, and this stimulates the sensory neuron. And when the sensory neuron gets stimulated, then eventually the G cells get stimulated, the G cells and the parietal cells. The G cells secrete the gastrin, and these gastrin act on the parietal cells again, and these parietal cells secrete the acid or the H plus. Now when there is enough H plus, then that H plus stimulates the D cells. Now these D cells secrete the somatostatin, and this somatostatin provides negative feedback or negative signal in the G cells and the parietal cells. This is how the gastric acid is secreted and how the secretion is maintained by the somatostatin and D cells. Now let's talk about the acute and chronic gastritis. Now, inflammation of the stomach mucosa associated with hemorrhage caused by the erosions, ulcers, or both is called as the acute gastritis. Now, erosions are a breach in the epithelium of the mucosa, but if that breach extends into the submucosa or deeper, then that is called as the ulcer. The causes include the NSAIDs, the alcohol, Helicobacter pylori infection, cytomegalovirus in case of AIDS patient. So sometimes the questions are framed like the patient is having AIDS. Now, which organism may be responsible for the acute gastritis in this patient? But now we have that audacity that we directly go for the Helicobacter pylori sort of option, but sometimes that option is not given, and the option given that is the right answer is the cytomegalovirus. Also, the cytomegalovirus associated esophagitis is also very, very common in case of AIDS patient. Now, there are some of the stress-related ulcers, like if the patient had severe trauma, burns, sepsis, central nervous system injury, those occurring with severe burns or trauma are called as the Curling ulcer, while those associated with the CNS injury are called as the Cushing ulcer. The hemorrhagic gastritis involves all of the gastric mucosa. Also, some of the conditions like uremia and anisakis. So anisakis is a worm associated with eating raw fish. These also can cause acute gastritis. The clinical findings of acute gastritis include hematemesis, melena, and iron deficiency. So let's talk about, in brief, the chronic gastritis. So the chronic inflammation of the gastric mucosa with the loss of the normal gastric glandular cells and replacement by the intestinal type epithelium, pylorus type glands, and fibrous connective tissue. So epidemiology, most common cause is Helicobacter pylori again, and the remainder of the cause is by autoimmune gastritis. So Helicobacter pylori associated chronic gastritis, we have discussed about this in the previous video, the structure and the pathophysiology of the Helicobacter pylori. But again, summarizing it all, so Helicobacter pylori is a spiral gram-negative flagellated rod that has corkscrew motility for penetrating the gastric mucus layer. The humans are the principal reservoir, and infection most likely occurs in the childhood. It colonizes the mucus layer lining within the antrum, and neutrophils are the primary inflammatory infiltrate and are noted within the lamina propria. They may also extend into the pits to produce the crypt abscess. Now, the SP or Helicobacter pylori is most commonly transmitted through the fecal route, and it attaches to the blood group O receptors on the mucosal cells. It is not an invasive bacterium and produces urease, protease, and cytotoxins. And these urease converts the amino groups in proteins to ammonia, and the secretion products produce chronic gastritis and peptic ulcer disease. These are common in areas of poor sanitation. Now, to identify the Helicobacter pylori, we have a highly sensitive and specific test available. The first one is the IgG antibody test, which is used for the diagnosis. And the second one is the urea breath test. The specificity of the urea breath test is typically very, very high. And another, we have the stool antigen test and the test to detect the urease in the gastric biopsy and the gastric biopsy with histological exam. And another, we have the gastric acid production is increased to slightly decreased in these cases of chronic gastritis. The serum gastrin levels are normal to decreased in cases of chronic gastritis. The stages of the ulcer formation. So initially there is erosion, which is typically limited to the mucosa. And when this erosion extends to the submucosa and muscularis, then that becomes a true ulcer. And when it goes deep down into the tunica muscularis, then that is called as a penetrating ulcer, because now it is going to penetrate into the serosa and there is going to be a perforation. Now, in short about the peptic ulcer disease, so it is an ulceration that is present in the stomach or duodenum, which is caused by the imbalance between the productive and the damaging factors in the mucosa. It is most commonly caused by the Helicobacter pylori infection. Let's skip all this because we will be discussing in detail the peptic ulcer disease in other videos. So the duodenal ulcer occurs in the first portion of the duodenum. This question is asked in the USMLE. The gastric ulcer occurred in the lesser curvature near the incisura angularis, behind the lesser curvature near the end of the pylorus. So perforation also may occur with a duodenal ulcer, and pain is referred to the soldiers. Epigastric pain is the most common symptoms, as we have seen in our patient. Grossly, the ulcers are clean, sharply demarcated, and slightly elevated round edges are present. Most gastric ulcers are benign, and a small percentage, that is 1%, may progress to gastric carcinoma. The complications of peptic ulcer disease include the gastric ulcer bleeding, perforation, duodenal ulcer, penetration into the pancreas, or stenosis. Thank you for watching. Keep studying hard.